All right, good afternoon, everybody. Thanks for taking time out of your lunch hour to join us this afternoon. We've got a very special guest. Dr. Maryjane Farr is joining us from UT Southwestern Medical Center. Dr. Farr at UT Southwestern is the section chief of heart failure, VAD, and heart transplantation. She is the Jackie and Charles Solomon Distinguished Chair in Clinical Excellence and a professor of medicine at UT Southwestern. And today she's going to be talking to us about the management of highly sensitized heart transplant candidates and possibly a little bit about transplant immunosuppression as well. So, Jane, thanks for taking the time out of your day today, and we're really excited to have you.
Hi, how you doing? Nice to be talking with all of you today. So we just have a half an hour. So boys, this is a hard topic for 30 minutes. So I condensed it a little bit, but I'm just going to go go rapidly, and you can always turn back to these slides at another time. So management of highly sensitized transplant candidates and recipients, and I include the word recipient because when I was training, there was so much focus on how to desensitize and very little that I learned, and had to learn this sort of the hard way. And what happens when you actually bring someone in for transplant, and how you manage the perioperative period and thereafter. Okay, so so key points here is understand the differential risk associated with specific HLA antibodies. I want to mention something about cross-reactive groups. We know that class 1 and also class 2 DR are highly immunogenic, and you are at great risk. Your patient is at great risk for early fulminant rejection if you're crossing in a significant way these antibodies, where the DQs, the class 2 DQs, are more later and smoldering, and they show themselves with coronary artery vasculopathy down the line. So I want you to appreciate that desensitization is only the first step in achieving a successful heart transplant, and appreciate that the perioperative induction plan may be inadequate. And so you need to be flexible and have a number of different options ready if your patient doesn't sort of behave the way you want them to. And mid to longer term data on strategies to manage DSA and chronic AMR is mostly a data-free zone fraught with indecision, nihilism, undertreatment, and also overtreatment. We're not going to have time to discuss all that, but it really is the case that it's hard to know what to do down the line. So a couple of cases: 38-year-old female with congenital heart disease. Baby turns blue after the ductus arteriosus is closed and is diagnosed with DTGA. The patient undergoes atrial septostomy for mixing, and then a definitive procedure with an atrial switch by Senning procedure. Multiple transfusions are required. And over time, as this person grows up, there's progressive systemic ventricular dysfunction and symptomatic heart failure. So when you try to think about a patient who needs a heart transplantation, one of the first things you want to do is it feasible? So this is this patient's HLA-1, class 1, and HLA screening. And as you can see, number one, the calculated panel of reactive antibodies are high in both categories. But you can see that there's, at least in my institution, a high cutoff of A2, 68, 69, a little bit more of B57 and B58. And what I'm looking at here is an ACREG, and I'll mention that in a moment. So a lot of antibodies in class 1, and there's a lot of DQs in class 2 at sort of moderate MFI. So that's the first case. Second case, 59-year-old female, multiparous, history of doxorubicin and cardiomyopathy, comes in cardiogenic shock, stabilized with temporary mechanical circulatory support. And then we check the HLA, and there's a lot of B antibodies, class 1. And so this case is a little bit different than the first one, because the first one is someone who you feel as though you can take your time in desensitization. And this patient, you really don't have a lot of time. And so, and then I just want to bring in a third case to bring you all the way to the other side of this. And this is a 25-year-old male with a history of congenital heart disease, sensitized, underwent transplant a number of years ago. I don't know the details of this patient's PRA prior or cross-match data, but for a lot of the pediatric transplants, you need to cross something more because of organ scarcity. certainly in the teenage years or the earlier adolescent years. This patient has recurrent rejection, ISHL2 grade 2 coronary artery vasculopathy, and there's been a number of treatments tried in the hospital to manage things over the years, plasmapheresis, rituximab, IVIG. We're going to talk about those things. And then there was another round where the rituximab was switched over for the antithymocyte globulin. There wasn't enough therapy that was robust here. The patient's maintained on a 4-drug regimen, and there are chronic class 1 and class 2 DSAs at a high MFI, but the heart function is pretty good. Maybe a little restriction is developing. This coronary vasculopathy is developing. And this is the type of patient that we often encounter when we adopt patients from a pediatric program. And you look and say, this patient, this graft is not going to survive all that long, but it's hard to know how you get after these antibodies. And sometimes people say, oh, no, you don't need to take care of that. But in all likelihood, they're impacting on the acceleration of vasculopathy. And this is certainly going to come up when you need to turn around and retransplant this patient a few years from now. That may be the first time programs say, oh, we need to manage these antibodies. So it raises the question of, even what do you do in this long term, and the toxicities associated with a chronic 4-drug regimen, and all this therapy that's already occurred. You can imagine that just the malignancy potential in this patient is extremely high. Okay, so what are HLA antigens? We know that class 1s are transmembrane glycoproteins found on all nucleated cells, and they're characterized by HLA A, B, and C, and also micas in this category are what we would think is sort of a non-donor specific antibody, but can be quite immunogenic in transplant. The class 2s are, there's an alpha and beta chain for each of them. They're polypeptide chains. They are found mostly on antigen-presenting cells and cells that are activated by either infection or inflammation or rejection. And they're characterized by HLA DPs, DQs, and DRs. I think when I was a training fellow, I don't think we knew anything about DPs. And I think we were just learning something about DQs, and that wasn't like a million years ago. So there are more things that we discover about HLA as time passes. We do know that HLA has subclasses of 1, 2, 3, and 4. 1 and 3 typically bind complement, and 2 only at a high epitope density, where the epitopes are the actual immunogenic piece of an HLA polypeptide or glycoprotein. And IgG4 is typically not all that immunogenic. Types of sensitizing events, as we know, transfusions, homografts, which of course is very important for patients with congenital heart disease, pregnancies, including miscarriages and abortions. And sometimes you can have a patient who's highly sensitized and there's a history that is not disclosed. Does it matter one way or the other? Not really. But you sometimes get surprised when you see sensitization in someone who doesn't sort of hit any of these categories. LVAD can cause sensitizations, all HeartMate 3 much less, and these tend to be natural antibodies or often class 1s that just sort of drift away over time. And vaccines your HLAs can mount and then decrease. And these sensitizing events or DSA are associated typically, as we know, with hyperacute humoral or antibody-mediated rejection, and also what we're calling chronic antibody-mediated rejection, including cardiac allograft vasculopathy as a form of chronic AMR. And as I mentioned, not all sensitizing events are created equal. I want to say something about the innate immune system and how the innate immune system or our responses to inflammation and injury can move into the adaptive immunity category. We know, at least when it comes to donors, all donors by definition are going through a tremendous amount of inflammation and injury, typically, obviously, head trauma. And within the graft or the potential graft, there can be activation of donor resident neutrophils, or in the periphery, resident neutrophils, macrophage, and dendritic cells, and can go into the graft and sort of set up a scenario where there can be breakdown or injury of the potential allograft, and there can be, a readiness for antigen presentation with peptide fragments. And so these types of things start to set the stage for an acute rejection event. But when we talk about solid organ transplant immunology, we're really talking about therapies that are targeted at controlling the adaptive immune responsive, adaptive or specific B and T lymphocyte responses. And the principal target of response are the MHC or the HLA molecules. So there's a couple of definitions of sensitization. One is antibodies against HLA that are likely to cause acute or chronic rejection after transplant, which limits the donor pool. As of 2020, upwards of 25% of patients on the heart transplant waiting list in the United States were sensitized, at least by a definition of PRA greater than 20%. So there's, again, just another description of sensitization. This comes from Monica Colvin and the AHA guidelines. But what we do know is that sensitization is associated with post-transplant mortality, graft loss, vasculopathy, and rejection. And typically, patients over CPRA of around 50%, we want to try to desensitize or have them wait for a long period of time. It's important that not all transplant programs offer desensitization. Okay, for those of you who are finishing your PGY 7-year, you are probably very familiar with a CPRA calculator. I'm going to bring you just the case one. So our case one, I was showing you here what the class ones were looking like, and then also the class twos. So the calculated PRA for this patient is 54% for class one, and if you include class two, it's 78%. So you could cross class two because the DQs will show themselves later on after vasculopathy, but they are difficult to contend with, and they're hard to sort of wrestle them to the ground, if you will. So you might want to try to avoid them. For the second case, where it's just class 1Bs, but look at this, just by putting in B51, 78, and 52, the higher MFIs, you've got a 78% sensitization. It's going to be awfully hard to do something with this patient on temporary mechanical support without, it's going to be hard to get a donor in time. So I wanted to raise the issue of a cross-reactive group. This was a concept that, well, not new to me, it's not old to me. And if you look at that first patient, this patient is sensitized against what's called the A2 Craig, 2, 68, 69, some 57, B 57, 58. So oftentimes with a Craig, and the second patient is sensitized to what's called the B5 Craig here. So let's go back to the A2 Craig. So I don't think, so sometimes when you see a patient that's got a pattern and you don't see a component of that cross-reactive group, you should expect it. And I think that's critically important, especially for retransplantation. Okay, so what are the issues in terms of sensitization? And that is that in contrast to acute T and B cell cognate interactions here where you're making new antibodies, antibodies of old, patients who were transfused as children or pregnancies over the years, they will develop memory B cells and sometimes long-lived plasma cells that are in these B cell follicles and just sort of what's called sort of niche areas of niche, sort of protected niches in lymphoid organs, and they're very, very difficult to treat. Importantly, long-lived plasma cells have lost CD20, they're CD19, and where memory B cells are still CD20. So when we talk about therapies, you really want to talk about how am I going to get at these germinal zones? Okay, so cross matches, there is no time to talk about cross match. All this to say is any patient that was sensitized, you are going to cross something. And most programs aren't using both of these modalities. We're typically using just flow and often a virtual cross match, sort of playing bingo at night, looking at these antibodies, but you're going to cross something. So you're going to have trouble or you're going to have to contend with something more robust in terms of induction immunosuppression and thereafter than somebody who, of course, is not sensitized. Getting at that is sometimes we use C1q assay or complement fixing assays or dilutional assays to try to get at what antibodies can I probably cross, because even though they may be at high MFI, if they're not binding C1q, or if you can dilute them out at a 1 to 8 or certainly 1 to 16, then you might say that you would cross them, knowing fully well that you're going to have to do something robust after surgery. And why do we do all that? Because donor-specific antibodies increase one's risk for coronary artery vasculopathy, examples shown here. Um, and then examples shown here by histopathology and then gross pathology. I mean, this is a very small lumen. And coronary artery vasculopathy is considered an immune-mediated panarteritis of the coronary arteries that markedly worsens your prognosis over time. And even on some biopsies, early after transplant, you may sometimes come across stenotic microvasculopathy, and that is that the pathologist will report, atherosclerosis, and you'll say, "What is that?" Well, it may be developing microvascular, a pathology or histopathology of microvasculature involvement. Important. This was just a quick paper looking at trajectories of cardiac allograft vasculopathy. And this paper written by Alexandra Lupe and colleagues was really about something else, which is how often you need to reassess with angiography and PET. But what was important about this paper, at least for the purposes of this talk, is they took a whole group of patients who had already been transplanted at two different centers and then just sort of phenotyped them. They did some um, uh, uh, random forest modeling to try to see what were some of the factors that were associated with coronary artery vasculopathy, and could we map these patients? And they ultimately mapped the patients into four different groups: those who never developed CAV, those who developed CAV late, those who developed CAV very early. And they clearly saw a signal in the trajectory four, and that is patients who had accelerated vasculopathy and then as a result should need more frequent surveillance. They were defined by patients who had donor-specific antibody. And so even though donor-specific antibody is not part of the definition of AMR, it clearly is associated with AMR, and it's clearly associated with vasculopathy. This was a paper that we wrote a number of years ago back at Columbia to show what did we see on our own large cohort. And what we saw, oh, where did my slides go? My heavens, we're going to go back to the STAR guidance. This is important. But here's the Columbia study that we saw that patients who were divided by either having no DSA or class 1 only or class 2, the prognosis was markedly worse in terms of freedom of rejection associated with class 2. So this is where these DQs and also DRs get involved, but DRs are much more immunogenic early on and then later on. Freedom from graft loss. So graft loss was associated with, again, with de novo class 2s. And then freedom from coronary artery vasculopathy, or lack of freedom from coronary artery vasculopathy, was associated with AMR with DSA. So let me go back to this slide. I don't know if anybody knows, or most folks know, what the Sensitization and Transplantation Assessment of Risk group is, the STAR group. And this is a very important set of documents, because what this document tells us in all solid organ transplant is when do we think it's reasonable, based on the literature, when we should assess for anti-HLA antibodies after transplant. And that becomes important because how do we know with what, the HLA that we're looking at, is it actionable? Is it important? Do we leave it alone? Do we not even look? All right, now let me jump ahead. STAR guidance. So some data that they came up with, which is preformed a de novo donor-specific antibody, is associated with worse prognosis. DSA is not part of the definition of AMR, but this may be changing. And DSA is associated with vasculopathy. Okay, I've made that point. Okay. This is a nice state-of-the-art review. DeFilippis and colleagues on the management of HLA sensitization in heart transplant recipients. So they go through all the drugs. I'm going to go through them one at a time. But just if you haven't seen this document, it really gives you a nice lay of the land. What's missing here is belatacept, and we're going to review that. But what I really liked about this paper is they put in peri-transplant induction strategy, and often you'll see a desensitization manuscript, but they'll just sort of stop it at time of transplant, or pherese the patient and bring ATG and go into the OR. And they never really talk about what happens afterward. And we know how critically important that is, especially when you need to turn to something really dramatic, like eculizumab or a complement C5 inhibitor, to wipe out antibodies that are are causing destruction. This is from Marlene Habal in Frontiers of Immunology, and here are all the different categories of desensitizing immunotherapies. So let's go back to the JHLT guidance, and sort of classically, you would typically you'd make a decision you want to desensitize a patient. Let's say you have time. You've got time on your side, like the first case. So you may start with plasmapheresis, IVIG, rituximab, or CD20 inhibition. But that takes a long time. You may then see that your patient fails this, and then you want to move on to a different strategy using plasmapheresis or bortezomib, which is proteasome inhibition, which works mostly on class 1s over class 2 antibodies. And there are some novel therapies, IL-6 inhibition and use of tocilizumab, which is a pretty straightforward protocol. This is just one example of a protocol. One question that always comes up for me, which is why I show this slide, is this takes a long time. This takes a long time. This, I think, more experience needs to be gained. But in the middle of a tocilizumab protocol, you could actively transplant somebody. You could actually do that here. You could do that here. Rituximab, you have some trouble with interpreting the flow cross match. So that's one thing. Timing about what you need to do and how quickly you need to accomplish it is important. This is just to show you what the surveillance strategy post-transplant is shown in the JHLT document. And it's pretty straightforward in terms of really emphasis on endomyocardial biopsies, emphasis on following antibodies. I would even propose maybe even a little bit more frequently. That's probably what our real world practice is, and high doses of immunosuppressive therapies. Okay, so let's talk about IVIG. We know something about these really are slides for you to keep. IVIG modulates the immune system and then can chelate some of the antibodies that are found in the bloodstream of our patients. And it's usually preceded by apheresis, which we really won't talk in detail about today. Moving on to rituximab, it's a monoclonal antibody, as I said, against CD20, and there's data to support its use if you have a lot of time. You know, CTAD11 reported on use of rituximab as an induction strategy, not necessarily desensitization, but an induction. And there was an increased risk for coronary artery vasculopathy. And there's a CTAD23 is going to come out, which shows you the 5-year follow-up on use of rituximab early in transplant. And so it's not totally clear how valuable rituximab it is. Maybe that's an overstatement. Sometimes it works, and sometimes you have to move to another strategy. So I'll move on to bortezomib, which is a proteasome inhibition. And as mentioned, and typically you can use, when you want to pherese patients, you pherese the patient, and when antibodies, and then these B cells will suddenly make more antibodies, this is a good time to give bortezomib. So including pheresis and bortezomib in one protocol is pretty standard, and it's reported in the literature. But again, if this is really for class 1s more than class 2, so that's important. Belatacept is a newer drug, although not so new to the transplant nephrologist. We're increasingly using this in heart transplantation, and it's a fusion protein of the Fc fragment of human IgG1 linked to CTLA4, which blocks T or co-stimulatory blockade of T and B cognate interactions. And I've used this protocol. Here's just a blow up of sort of exactly where Bella works. And we use this in a desensitization strategy when I was back at Columbia, using a combination of a standard pheresis, IVIG, bortezomib protocol, but then also adding belatacept. And we found some efficacy to this strategy. This is a strategy that was probably pioneered by Anita Chong at University of Chicago. Other strategies that you can use, for example, IL-6 receptor antagonist tocilizumab. So IL-6 inhibition can markedly decrease B and T activation, innate activation, and you can actually transplant in the middle of a tocilizumab protocol. I've only used this a couple of times, but I'm interested in using this a little bit more often. One problem with tocilizumab is there was a lot of reports of fungal infections during its use with COVID, which so people sort of shied away from that, but it's a very good drug, and at least for an induction, there's another CTAD trial that's ongoing with use of tocilizumab for induction. Okay, so this is the use of daratumumab, which is a monoclonal antibody against CD38 found on plasma cells. So really effective for patients who've been sensitized for a very long period of time. This was an ACC case, and I thought it was nice because it demonstrated the use of this drug. And you can actually, I asked this question at ISHLT with one presentation on CD8 inhibition, and you can transplant sort of right in the middle of it. One of the downsides is that maybe there's loss of regulatory B cells post-transplant, but I really think that's a nuance that clinically isn't all that helpful when you're just trying to get someone to transplant. And then lastly, heart after liver transplant is an option that's been pioneered mostly by the Mayo Clinic. And if you can see, for example, A2 highly immunogenic, and then here is a DR for also highly immunogenic. Put the liver in first, and these antibodies drop right down. I will say there was a case that in my institution, we recently entertained a heart after liver transplant. And my HLA immunologist, we sort of laid out all the antibodies, and she really felt that the liver could not take care of the burden and the immunogenicity of the antibodies that we still had with this patient, despite a number of rounds of desensitization. So just because you put a liver in doesn't mean it's going to work out in every case, and I think that's important. Um, people always talk about IgG endopeptidase, which is from strep pyogenes, and it literally can cleave IgG 1, 2, 3, and 4 antibodies right away. And here's an example here where here are the levels before treatments, and here are the levels right after. This, I've never used this. I know Utah just used this, and I think quite successfully with a patient. But if you'll notice, you can deplete antibodies right away and have this sort of early postoperative period of quiescence, and then boom, these antibodies are going to come right back. So it's really here where you need to figure out what's your next move. Okay, so this is just a quick case. We've got a few minutes. 61-year-old woman with ischemic cardiomyopathy. She's got a heart wear, LVAD, lots of complications. And actually, this transplant occurred before we even learned about all the heart wear recall. She's highly sensitized. Look at her class 1s and 2s. So we put her through this bortezomib belatacept protocol, including plasmapheresis and IVIG. And we brought her to transplant, and we did that on the basis of a negative prospective CDC. So there were lots of antibodies on the flow, but the CDC, which most centers don't use anymore, we moved forward, so we proceeded. Now, so we gave her, we didn't pherese going into the OR, we probably should have, but we just gave her steroids and a bunch of medications, including ATG. In retrospect, we probably should have given her intraoperative thymo. I don't, anyway, that's where, but we put in a pheresis catheter, and everything was fine postoperative. We were amazed that she was doing fine, and then suddenly she was not. All of a sudden, our cardiac output is dropping precipitatively. She's having non-sustained VT. Her bedside echo, the LVEF is 15%. She is having a fulminant rejection. So we quickly had to request eculizumab, which is important. Eculizumab, you have to have it ready and available, and you have to have thought to have vaccinated your patient against meningitis prior. So anybody who's going through desensitization should be fully vaccinated, including meningitis. So we quickly used eculizumab, which is a complement inhibition, and that can work very, very quickly, very well, similar to itis, but it's a prolonged course of infusion therapy that's extremely expensive. And there's data to support this. The Cedars-Sinai group created most of this data. Anyway, so we went back there. So we gave her eculizumab in addition to more ATG, and she responded very, very well. So wonderful, everything's great. We're going to put her on an eculizumab protocol, but really the point of this is the management is just beginning. This patient now is about 5 years out. She's doing very well, but she has received a lot of immunosuppression over the years. And while she's probably on 3-drug regimen right now, but a lot of these patients need 4 drugs, sometimes 5 drugs when you add methotrexate. Some of the work that I'm doing right now is to use belatacept after transplant in the first year or second year to manage donor-specific antibodies that we think are important, crossing chronic AMR. Photophoresis is another way to do it. But again, there's such a data-free zone that you have to develop the data, but you have to also be cautious about what is too much immunosuppression. Where are you in such a data-free zone that you really cannot proceed? How do you, there's a lot of HLA antibodies that are totally quiescent. They're not bothering the patient whatsoever. So there's got to be a clinical indication to go after some of these antibodies. But anyway, so the journey of managing someone who's highly sensitized is not just some of those difficult decisions before transplant, but it's being very mindful of the different strategies you need to employ perioperatively and then postoperatively in the short term and in the long term. So these are some resources. There are many more, but these are at least some of the resources that I used for this talk. So I'll stop there, and if appropriate, I can answer some questions.
Well, thank you so much, Dr. Farr. That was a fantastic presentation. Received some text messages during your talk about how wonderful of a talk it was from some of the spectators. And I think for me personally, I'll have to go through and watch this again to really take home a lot of those points. And just a reminder to everybody, these lectures can be found on YouTube later on. I did put that link in the chat. So if you want to go back and rewatch this lecture at a later time, to try to make sure you really understand a lot of these things that Dr. Farr talked about, you'll have that opportunity. Any questions there from the group? If you'd like, you can go ahead and feel free to unmute yourself and ask the question, or if you want to put your question in the chat, then I can ask that question for you.
I can see one here. First of all, I'm sorry I talked so fast, but I removed so many slides. This is definitely the type of lecture where talking more slowly is the better strategy. So this is from Matt Colna. Patients with vasculopathy and low-level DSA, instead of sirolimus, is there a different strategy? Yeah, because sometimes the sirolimus works or everolimus in combination with CNI, not as CNI sparing, in addition to maybe a third drug. As I said, I'm starting to use some belatacept in some of these patients as sort of a non-bolus, infusion therapy monthly and then bi-monthly when you can't get control of some of the antibodies and the patient's already been in the hospital for more aggressive therapies. At some point, antibodies tend to accommodate. In the early postoperative period, if you've got someone who's making a lot of donor-specific antibodies, but they've had infection, just giving them monthly IVIG, which is more of a transplant nephrology strategy, is sometimes enough to just get the antibodies to sort of quiet down. Can you comment on when a patient is waiting in the CCU, requiring a transfusion, how to proceed? Well, it's a tough one. Sometimes you'll have someone who's quite sick and they've bled on their Impella 5.5 and their hemoglobin is 6 and you just can't get away with it anymore. And you can transfuse. If you can get that patient transplanted in about a week or two, it's not going to be so common that they're going to make antibodies. So I think there's a way you can get away with it. Use transplant them and just do a retrospective cross match just in case. Labi, I don't know if you can speak, but what would you do?
Yeah, that's the same. First of all, thank you for that wonderful talk, Maryjane, and I hope I'll see you in at ATC if you're coming. Yeah, I mean, there's no right answer for that, right? I mean, it takes a little while to develop antibodies and can't immediately check for cross reactivity. But yeah, just that case, it's a little tricky.
Anybody else? I'll make one final comment, and that is, I have to say, I was a junior attending for a long time before I really understood the difference between looking at antibodies. And this is where your HLA immunologist can be so helpful. I now see a DR and I get very, very nervous because that's a patient who's going to get very, very sick on you. I see DQs and I feel like I've got an obligation to look at a long-term strategy. When I see the A2, 68, 69, B50, I see, oh, that's an A2 Craig. This person's really reactive. I have to take care. I have to think about all these other antibodies in this Craig. And those are some of the nuances where that's what an immunologist see. They see patterns of risk. But as cardiologists training in this area, we kind of get that sort of all HLA antibodies are created equal in there. That's absolutely not true. So I think that's really important to ask your HLA immunologist, what are you seeing? What are you worried about? Tell me why you're worried about it. Tell me why you think I can cross this or that. And you'll learn, you'll continue to learn through your career on in this, on how to approach these things, even without having to go get a PhD in immunology.
Fantastic. Well, thank you again, Dr. Farr, for taking the time. Thanks
Yeah.
for us, and we'll get together again sometime real soon.
Okay, good. Take care. Love you. See you at
Yeah.
ATC.
I'll see you soon. Thanks.
Bye.